Live. Good morning, everyone. Welcome to our weekly Medicare training. This week, Paul is going to be discussing as it says on the screen, the effective strategies of the Medicare market. So what to expect during AEP, how to go through AEP, and then beyond. So he's going to be talking a lot about the plan year of 2025 and kind of the ins and outs of how to go through things, what to expect, what you need to be doing, things of that nature. So we're going to hand this off to Paul. He's got some wonderful information. And as always, go ahead and put any comments that you have into the comment section, and we will try to get to those as we come across those particular topics. So take it away, Paul.
Good morning, everyone. I am going to try to simplify all of this Medicare chaos. But I first wanted to tackle, I've had a lot of conversations with agents, whether they are veterans, excuse me, been in the business for 4, 5, 6, 7 years, even agents like me that have been in the business for now, this will be my 18th AEP. No matter how you slice it, we all feel underwater because there's a lot of changes going on. Now, all of those changes really bring up a lot of opportunity. So first, I want to explain what these changes are, how to attack those changes and make that an opportunity for premium growth. Because I do see that this is going to be a huge year. I have agents that I spoke with an agent this morning. She is talking with the managers of a group of housing complexes. It is 13 housing complexes that are full of Medicare eligibles. And most of them are going to fall kind of in this tiny little crack that we're going to talk about here in some of these SEP changes. So these folks talk to her immediately between October the 15th and December the 7th. So she is ready to lock and load. Hey, I've got all of these opportunities right here at my feet. And here's 13 housing complexes that are full of one type of population. So her opportunity for growth is absolutely enormous. So we're going to kind of go through these changes. I'll explain what is happening to the Medicare market as best and as fast as I can. This is a big beast, but we're going to kind of go through that. We're going to go through some of the changes to the election periods and what you need to do to maximize your opportunity, not just for AEP, but in the months beyond AEP with the things that are happening. We're also going to talk about what types of plans are available. With all of this disruption in the market and the rule changes and all of these other things, that creates a lot of blackjack. We're taking cards off the table, putting more cards on the table. So these plans are now changing. There's a lot of changes to the SEPs with the changes to that. That creates changes to the plans because the market has to adapt to what is changing with the rules. And then we're going to try to get into evaluating what is happening. Each state is different. I just went over the state of Virginia with my group. They're at like 38% MAPD penetration. Some states are at 60, 70, 80% penetration. But we're going to talk about the numbers in greater detail about the opportunities that are out there and what could be at your fingertips. And then we're going to try to tell you how to organize all of this and manage it all, because there's going to be a huge eruption. And the bubbles of the volcano are starting to crest off the top of the volcano. And it's September the 17th. We haven't even really gotten into the meat of enrollment season, but there's already a lot of stuff churning out there. So let's talk about the Inflation Reduction Act a little bit. Very, very briefly, there's a lot of changes going on. Many of the changes that are happening this year are due to the Inflation Reduction Act. Not all of them, but many of them are responsible for what is happening. The Inflation Reduction Act didn't just get dropped on us all of a sudden out of the clear blue sky. It has been happening, and it will continue to happen over the next few years. And so many of you have heard, oh, there's the $35 insulin. A few years ago, that was hey, some plans did it, some plans didn't. It was a demonstration of, hey, we'd like to try to do this. Let's see how it works, see if the carriers are comfortable with it, so on and so forth. Now that is mandatory. But a few years ago, that was the part of it. Okay. You've heard about all of these talks back and forth about the negotiating power of Medicare. All of these millions of people clustered together to negotiate with the drug companies. Okay. That is starting to happen. We now are at this point on this wave where we now have the $2,000 troop and the closing of the donut hole. That is all part of the PDP structure of everybody's Medicare plans. We'll get into that in a little bit. But this is about where we are on this wave. We're about halfway on this wave. We're cresting over the top, so to speak. We've built up a lot of momentum and a lot of things are happening all at the crest of the wave. Okay. So that is starting to happen to people's plans now. Now, also in the background, the first 10 drugs by Medicare, the most expensive ones that most people use, I don't know how they exactly decided these, but kind of the Jardiances and the Xareltos of the world, if you immediately know the name of that drug and know how to spell it, it might be in those top 10, okay? Because those are expensive drugs, typically speaking. Those are the ones that they are negotiating right now. But those prices won't actually hit until 2026. So this wave is going to continue to happen. By 2027, they're going to have negotiated over 100 of the most used drugs in Medicare. Okay, so there's a lot going on. We're kind of at the crest of that precipice of, hey, man, you want to catch this wave and ride it before that wave kind of dies out. But there's still more to come. More change means more opportunity. So make sure you're looking at that opportunity and you're looking at it through the correct lens of what's going to happen to you. Okay. So what does the Inflation Reduction Act do to Medicare? Well, on the PDP side of it, since it deals mostly with the drugs, in most cases, your premiums are going to go up. Not all, because also here in the last couple of months, just like the demonstration that said, hey, we're going to make insulin $35 if y'all want to sign up for it. They've also done another demonstration to help bring down those premiums. Okay. Some of these carriers are signing up for that demonstration. If you're having a real hard time finding the price of what a PDP is going to cost for fill in the blank carrier, that may mean they're part of the demonstration. They're still shuffling the deck on how much these costs are going to be. Okay. There's going to be a higher deductible in most cases, not all. But now sometimes here in Virginia, there's an enhanced plan that the premium actually went down. If you're on an enhanced plan and you look at your ANOC and the premium went down, hey, I'm a happy member. But if they look a little bit further into that ANOC, if you all remember me pulling out saying you got to get these people to look at their ANOC, now I have proof. The people on that enhanced plan, their premium went down, so they sound happy. But their deductible tripled. Are they going to be happy when they use that drug plan? Probably not, depending on what drugs they're taking. So we need to have that conversation with these clients. These are the things that are happening. This is what's going to cause the chaos. So understand what's happening so you can talk logically to it. You can be the subject matter expert. Now, certain drugs are going to be shifted around from tier 3 to tier 4 to tier 2, blah, 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 depending on how they get negotiated at these drug companies. And you've got to remember, these drug companies only have to carry 2 of every drug. So if there's 500 insulins out there and they have to carry every one of them at $35, they're going to carry at least 2 because they have to, but they're not going to carry 300 or 400 different insulins. They're only required to cover 2. So that's every category of drug. Cholesterol, right? Diabetes, high blood pressure. You pick the category of drugs, they have to cover a minimum of 2. So there's going to be some reductions. They're going to tighten up those formularies because they negotiate a better price with this drug company. What happens when the costs of these companies get pinched? They pinch the benefit, okay? Now, in the PDP space, that's going to be very ugly because the Inflation Reduction Act directly goes after drugs and the costs of drugs. There's nowhere to hide there. Now, MAPDs, they have their Medicare Advantage plans with drug plans built in. That's what the PD stands for, prescription drugs. Okay, Medicare Advantage with prescription drugs, MAPD. Since there's that medical portion already there, we can kind of hide some of the ugliness of the prices going up. Okay, but they're already under pressure from what's called medical loss ratio. Too many benefits are being used to pay for medical expenses. So we don't have a lot of money left over. That percentage has gone way up. Since that's gone way up, they don't have as much money to play with. Inflation is happening to them too. So guess what? They're pulling back the benefits. Now they're going to hide some of these big drug costs, but they'll still have some tier shifts in the drugs and some formularies. They'll have some deductibles that change, but they're going to shift a lot of this to the medical side of the puzzle. Once they shift that to the medical side of the puzzle, now their premium or their hospital copays may go up, or their skilled nursing facility costs may go up. As those go up, congratulations. Now we have costs going up on the medical side to hide the drug ugliness. Okay, so this is what Inflation Reduction Act is doing, not necessarily on purpose, but that's what these plans have to do to adjust to the new set of rules. Okay. Now, one of the other things that's changed, that we talked about, is the change in the SEPs. Okay. One of the big changes to the SEPs is they're trying to separate people out. At one point, everybody that was dual, meaning they had Medicare and Medicaid, and everybody that had federal income subsidy for their drugs, were all clustered together into one big election period. And we just flipped people left and right all year long with this election period. They changed that. Then they made it a quarterly SEP. Now they have changed it again because they're trying to separate out based off of who has what type of subsidy. So let's just say we have low income subsidy. That means the federal government is helping to pay for our drugs. Once again, the Inflation Reduction Act going after drugs. So those folks, we're trying to separate out all of these different groups. Those folks after AEP will have one election period every month to move a PDP plan. Right now, they can use their election period to go to an MAPD if they want. We can add medical coverage. But the government says, no. We are only subsidizing their drugs. So the only thing you can move them forward on in 2025 is a drug plan, unless they have another election period. So, okay, hey, not a problem. Understood. Got it. So what do we do with all of these duals? Because right now this election period is slapped together. Well, now there's a dual SEP. And for those that are fully dual eligible, they'll have a month-to-month availability plan to select anything they want to select because they're fully dual eligible. They get federal subsidies for their drugs. They get state subsidies for their medical costs, and they have Medicare. So there's 3 different hands in their bucket paying for their medical costs, almost 100% of their medical costs and their drug costs in most cases. But they have a month-to-month decision. So therefore, I can move them at any time of the year as long as they are eligible. And then there are the folks that are partially dual. Partial duals are the folks that are eligible for that medical assistance from the state, but they don't get full assistance from the state. Now, those benefits vary from state to state. We're not going to get into all of that. But now those people that are not fully dual eligible, that dual SEP is basically for the duals. The people that are partially dual eligible, their election period almost matches the folks that are LIS. I have to move them during AEP because they don't have an election period to move to another MAPD in most cases. It varies by state. But you've got options there. But understand what those options are. And that means I have to get anybody that I know that has just their low income subsidy from the federal government. I got to go grab those people and get them to move plans before December 7th. Because after December 7th, on December 8th, the clock is stopped. I cannot move them the rest of the year, and they're locked in. So we're separating out what type of each person it is. So I have to target in AEP which people don't have election periods after AEP. Okay, so we'll get into that. Who do we target in what order, and how do we target them in what order in just 1 second. Okay. So then there's all of the folks that are duals. We talked about the full duals and the partial duals. Okay, because of this, the plans are currently using that dual LIS election period that I alluded to previously up until October the 1st. So they're running around these next 2 weeks trying to slam everybody into as many plans as they can. That's what's happening right this second. Okay. Some states are cutting benefits to their partial duals because COVID funding has ended. And when COVID funded ending, they put a whole bunch of people on Medicaid rosters, and all the people that were on Medicaid did not have to reapply. They were just left on Medicaid for all eternity. Well, now that the FEMA disaster of COVID is over by the federal government standard, all of these people are being redetermined. And that is disenrolling millions and millions and millions of people, mostly because they just didn't fill out paperwork. Because the last 4 years, they didn't have to fill out paperwork. They get something in the mail that says, hey, fill this out to keep your benefits. Oh, that looks crazy to me. I'll throw it in the mail, in the trash, because they haven't been used to filling out the paperwork to be redetermined that they do have Medicare. And so now they call it unwinding. Okay, so there's all of these people that have been unwound from their Medicare and Medicaid all over the world, all over the country, and they're looking for assistance to get reapplied to Medicaid. They don't know how to do it. Okay, so helping them on this process can give you an opportunity to be their agent, and then sign them up for a duals plan, and then sign them up for other things as well. Okay. Now, the advantages of this DSNP market, health assessments will pretty much always be paid as long as the government doesn't change those rules. So you'll be paid for the enrollment, and then you'll typically be paid for a health assessment questionnaire after the enrollment as well. There are no foreseen cuts in the commissions on DSNP. I cannot say that for everything else. Still one of the highest enrollment segments of the market, as far as these people are literally sitting around and need to be enrolled in plans. And a lot of them have been kicked off plans, and they don't understand why. So being that subject matter expert that can come in and help them get their benefits back, you're building that trust before we even get to the sale. Okay. Then, because of all of these changes, I can't use dual LIS SEP as many times as I used to do before. For the majority, 80% of people that are dually eligible have more than one chronic condition. And surprise, surprise, almost 60% of all Medicare eligibles have at least one chronic condition, and that's called diabetes. So the new market, the new place that everybody's going to be chasing, because of all of these shifts, the new SEP is that chronic condition plan. Now, previously, if you had a chronic condition, you could use that election period one time per year. Now you can use it in 2025 12 times per year if you want to. Now, depending on the availability of the C-SNP plan in the area or the zip code in which that member lives, what qualifies them for a C-SNP, easy for me to say, what qualifies them for this 12 months of enrollment is, do they have the qualifying condition that will be able to enroll them in the C-SNP in the same condition at that time? So is my client diabetic? Is there a diabetic C-SNP plan available in their zip code? If there is, and I need to focus on other opportunities such as MedSup and PDP folks that need to be moved during AEP, I will politely ask my member that has a chronic condition to let me move them later in the year if I need to. This is how understanding what's happening to me buys me more time to sell. Understanding enrollment periods, Medicare feels like a start and stop. It doesn't necessarily have to be a start and stop. It's about understanding what's opportunity in front of me. And so remember, Medicare and health clients pay your bills, right? I don't remember who it was. It might have been the great Skylar Smith that told me this, but Medicare pays the bills. Life insurance plans pay for vacations. Annuities pay for additions to the deck or additions to the house. So understanding how I can sell this health product year round really helps you become a much better agent, not just as a health agent, but as an overall selling machine. Because now when times get tight and it's hard to sell, because there's ebbs and flows in selling life insurance. There's ebbs and flows in selling healthcare. So understanding what my opportunities are and how I can maximize those really pays off. So let's talk about this low income subsidy thing just a little bit. Okay. There's low income subsidy that is federal government mandated program where the federal government subsidizes their drugs. Because of the changes to the plans and the changes to the partial duals and all of these other pieces to this puzzle, right? Once again, the plans have to adapt to what we can sell. So there's going to be a lot more low income subsidy plans out there. That's going to be massive growth because there's a lot of folks that qualify for LIS that don't qualify for partial Medicaid. There's a lot of folks that that qualify for LIS, and there's even more that don't qualify for full Medicaid. So understanding these movement of these parts and how that movement will be curtailed. If this person's on a PDP only, I got to get them on an MAPD before the end of December 7th. So I've got to create that urgency. If this person tells me, oh yeah, I've got original Medicare and a drug plan. I've got LIS. Yeah, that's perfect. The rules are changing. So I've got to create the urgency to get them to move now. If they're already on an MAPD and I'm swamped with business, I can move them during the OEP opportunity, January 1st through March 31st, but we'll get into that later as to those SEPs. But understanding that the SEPs are changing, I've got to move the people, this LIS person, because they're PDP only, I have to talk to them on December 7th. Have to. If you want to apply, thank you, Skylar. I'm assuming that was Skylar that put that up there. If you want to apply somebody for Medicare low-income subsidy, you'll use that website right there. And applying them for low-income subsidy can earn you an election period as well. And then you can sell them these low-income subsidy plans. Okay, so once again, the election periods are changing, so the plans that are available for me to sell are starting to change. There's going to be more of these low-income subsidy plans out there. So understand what those are, okay? That gives you a lot more opportunity to sell depending on what it is. There's going to be new plans, new carriers. The movement of these eligibles will only be for their PDP until December 7th, unless there's another SEP available to them, such as this person's not on just the PDP, they are LIS eligible, and they have a Medicare Advantage plan. If their Medicare Advantage plan is not the best one for them and this low-income subsidy plan is better, I could move them in January if I wanted to. So understand how that works so you can buy yourself more selling season. I can't buy more AEP. There's no way to do that. But we're going to be swamped. We're going to be busy. Let me figure out a way to buy more selling season by understanding my election periods a little bit. So these PDP changes are going to create chaos. Okay. Once again, the Inflation Reduction Act is aimed directly at the prescription drug prices. Not directly aimed at a PDP plan, but it's aimed at the drug prices. The premiums, the deductibles, the tiers, the formularies, the networks, all of this is going to change. So like I highlighted before, I've got a client, hey, I've got this letter that says my premium went down. Okay, read a little bit further. What does it say about the deductible went up? Okay, great. Understand what it is that you've got in your hand. So that ANOC is massively important. So just like that last week conversation where we were talking, I got to get these people on the phone. Have you gotten your ANOC? Do you understand what it is? This is why. Because the member says, hey, I'm happy. My premium went down. No. I need you to understand your deductible went up. Okay. The majority of the shopping is going to be triggered by these Inflation Reduction Act changes, and it's going to be for the PDPs. And there's nowhere to run and hide on these costs for these PDPs. So if the member has a PDP, they need to look at their ANOC. And it needs to be so stressed to them that by December 7th, if they haven't made a choice, it's over. I can't help you. Now, if you're selling a PDP and moving them to another PDP, congratulations, you've gotten a client. You probably sold them a MedSup as well, right? But understand which PDPs are paying and which ones are not, because some of these PDPs are not paying commissions. Now, you've got to come up with a strategy for dealing with these clients. If that's the best plan for them, how do you want to deal with that? Do you want to let them enroll? You want to help them enroll? You take them to their website, whatever you want to do, that's up to you, right? Do you want to help build the trust? Yeah, I'm not going to get paid for this, but I wasn't going to get paid much for it anyway. It's a PDP, right? The cost implications of the PDPs and the fact that the Inflation Reduction Act is aimed right at the drugs is going to increase the likelihood that yes, Anna Lynn, well, Carrie is one of them. We're increasing the likelihood that people are going to go to an MAPD. The Inflation Reduction Act is aimed at drugs pricing. There's nowhere for us to hide the pricing changes and all of these things in a PDP. PDPs will become more costly on the premium and the deductible side, even though the maximum out of pocket went down. So those cost implications increase the likelihood that these people want an MAPD. The grandest advantage of this is 90% of everybody that is Medicare eligible in the United States has some form of a drug plan. That has to be creditable coverage. So there's going to be a lot of people that are going to have changes to their drug plans this fall. 90% of all Medicare eligibles. Now, we kind of alluded to there's a lot of pressure in the PDP landscape. We talked a few months ago about MedSup pricing going up. What does all of this mean for the Medicare Advantage landscape as a whole? Once again, massive growth is anticipated. We'll talk about the amount of growth we had in 2023 to 2024. Even more is anticipated in 2025, from 2024 to 2025. Because Medicare supplement rates have increased sometimes as much as 21%. Maybe even more. I haven't come up across more than that, but maybe Skylar or somebody on this call has. Okay, but these premiums have jumped dramatically because medical loss ratio, the costs of doing business in the medical space is going up. Now you've got these PDP premiums that are probably going to go up, and you got the D-SNPs and the C-SNPs and all of these other SEP changes. All of these other things are rattling the cage, right? And when it all shuffles down, yes, there's even going to be some folks that are going to leave their markets of MAPDs. We'll get into that in a little bit, right, with plan exits. There are PDP plans that are exiting. Some PDP plans are exiting the entire country. So these drastic changes are all like most of this, the most drastic change in the Medicare Advantage space would be a plan exit. Okay. A plan exit is this plan number, whatever it is, no longer exists in state X. That is happening. There's also what is called service area reductions, where the plan may not exit a whole state, but due to networks or whatever, and all of these other cost implications are making networks tighter, right? You may have a situation where the plan exists in all but 2 or 3 counties. There may be one county where the plan pulls out because they don't have a rheumatologist. Something random like that. What are those when the plan gets pulled out, whether it's a plan exit or a service area reduction? That's an opportunity. Because now these people, their plan is exiting the field. That gives them an SEP, which we'll talk about. That also gives them guaranteed issue rights if you want to sell them a Medicare supplement. There's going to be ancillary benefit reductions, and they're going to be hospital and skilled nursing facility charging increases because they're going to bury the ugliness of the benefit changes. It's not like all of a sudden the premium went from $0 to $50. Once again, just like on that PDP for my client, they buried it down into, it's not on the top line. This is an ugly plan all of a sudden. They buried it down in the benefits, and it's going to be in the ancillary reductions, hospital charges, skilled nursing facility charges. Those things are going to be pulled up and down like little yo-yos, and sometimes just ripping out benefits, transportation benefits, silver sneakers benefits. If it does not affect their star ratings directly and they have to pay for it, they're going to rip it out if it's not being utilized enough. So that's what's going to happen in the Medicare Advantage landscape. Sounds really scary. Remember, 90% of all of those PDP members, all of those 90% of those people all have PDPs? Well, there's 67.4 million Medicare eligibles. 90% of them have drug plans. The Inflation Reduction Act touches 90% of those 67 million people. Now, 51% of those currently have a Medicare Advantage plan. 51% depending on states, it's up or down or whatever, right? But that's 51% nationally. Medicare Advantage plans grew 7% from 23 to 24 and overtook 51% of all eligibles in the Medicare space are now on a Medicare Advantage plan. Supplement prices are up. Premium prices on PDPs are up. All of these costs are rising, and they're pushing everybody into a Medicare Advantage plan because the premiums fall. Now, there's 34 million approximate that are just on original Medicare. So that's just original Medicare and a PDP. 51% have MAPDs. Now, on an average AEP, before the Inflation Reduction Act ever was created, on an average AEP, anywhere from 10 to 15% of all Medicare eligibles will be shopping around and changing plans during AEP. 10 to 15% in most years. Because of the Inflation Reduction Act and all of these changes that are going to touch all of these people, estimates range between 40 and 70% of all Medicare eligible people will be shopping this AEP due to the drastic changes. There's a whole lot of disruption. There's a whole lot going on. Now, I've got to retain my members if they're already on a Medicare Advantage plan or something like that with me. But with all that going on, an organized agent, just like I led with my agent that has now these 13 facilities that each have clients that we've just talked about that have C-SNPs and D-SNPs and all of these other opportunities. She has 13 housing facilities at her fingertips ready to move them. So an organized agent can capitalize on their growth, and since it's typically 10%, we're now talking 40 to 70%. An organized agent like her could potentially grow 400% more than her average AEP. And her average AEP is between 80 and 100 plans. She is already booked between October and Thanksgiving with at least 3 to 4 appointments every day. So if you can get yourself organized and you can get in front of these people and you know how to do it, you can make yourself a lot of money in this business this fall. So make sure that you are getting yourself organized and you are understanding what is happening. Now, all of this change equals opportunity. So who do we focus on? How do we get them organized? What order do we put these people in? If you are on a PDP with original Medicare or a PDP with a supplement, the clock is ticking. December 7th is the end. If you're an MAPD partial or you have LIS, depending on what you are already on, December 7th may be the end. If you're already on an MAPD, I have until January 1st through March 31st, the MAOEP to move you. If you have a chronic condition, I have the chronic condition SEP next year to move you. And if you are full benefit dual eligible, I have those SEPs to move you. So you need to understand what order you need to put these clients in what order of importance based on the SEPs that we just talked about. Focus on those that are losing potential SEPs. If there's a plan exit in your area, on October the 1st, you can start talking about plan exits. Advertise. Is your plan exiting your area? If you need help picking a new Medicare Advantage plan, please let me know. This market disruption between the MedSups and the PDPs, the MAPDs with the split service area reductions and the plan exits and all of these other things that are pulling at this system is a huge opportunity. If there are plan exits of a major carrier, and some major carriers are pulling out of some areas, if all of a sudden there's hundreds of people that are going to be quote unquote orphans, you need to figure out how to get in front of those folks. Do we need to do a seminar about your plan exit? Oh, there's some plan leaving this state, and I have a guess a whole bunch of them live in that building. We need to do a plan seminar near that building. But growth is your focus during AEP. So organize your AEP off of those SEP changes. You need to grow as fast as possible because everybody has an election period. As we just outlined, not everybody's going to have an election period after AEP. So let's make sure we've got it organized and lined up in the right order so we can grow as much during AEP as we possibly can. Once we get into the OEP and the C-SNPs and the D-SNPs, those are retention for my churn people. I need to change you to a different plan, sir or ma'am. Can I have an appointment with you on January the 3rd? I have to deal with all of these people on MedSups and PDPs. I got a mountain of them right here behind me. So I got to deal with those people first because their clock is ticking. So I appreciate your business. I will not forget you. Let's set the appointment now. And I will call you after the first of the year. Enjoy your holiday. Enjoy your Medicare plan. When the plan changes, I'll be at your front door. So what is all of this? What advantage is all of this to you all? With all of these plan changes and the hospital upcharges and all of the other things that are going to happen in the Medicare Advantage space, portfolio expansion is going to be huge. Getting in front of anybody that has Medicare. Remember, 90% of them have drug plans. So getting in front of just about anybody that has Medicare is a ripe opportunity because they're going to have questions. But churning is not necessary during this AEP. I don't need to just move you. I got to organize based off of who you are and what election periods you will have all through 2025. Full benefit dual eligible folks, I appreciate you very much. Enjoy your grocery card. Enjoy all of these benefits. I'll see you in January because you're full benefit dual eligible. So without a real good reason, I should not be churning these people because in some cases, the grass is not necessarily greener. If I move you from one MAPD plan to another, they've just shuffled how the danger is exposed. So I may want to consider selling a hospital indemnity instead of just churning you if I have to see you during AEP. So portfolio expansion is a big deal this AEP. Now, because of all of these 90,000 bazillion people that will be floating around, let's make sure we're using technology to our best advantage. Now, Integrity gives us a lot of neat tools with the Medicare Center and the Client Sync. Plan and roll, all of those different tools that they can use in there. That's a very neat, fast, slick way to get the business done. Make sure you are using those, using Calendly invites, personal URLs. If you've got a CRM tool, those types of technology upgrades will make you faster. Speed leads to efficiency. Efficiency leads to more sales. More sales leads to more commission. So focus on that now while you've, knocking over my coffee mug. Focus on that now while you've got time. Okay, if you have time. I got to get we talked about getting our bookmarks all lined up for all of these portals, get all of that stuff organized, because now is when I've got to be fast. So we talked a little bit about plan exits and the different disruptors and whatnot. Here are some of the other things that are happening. Some MAPD plans and some PDPs will be non-commissionable. So make sure you've got a good eye on what you're selling. Okay. As Anna Lynn pointed out earlier, well carriers is not something we want to sell right now. On the PDP side anyway. IRA changes, leading to the shopping, especially on the PDP, but some on the MAPD side as well. Understand why those changes are happening so that you can actually talk to these folks. Okay. The supplement price increases, that is jumping off the charts. Some of those folks have already grumbled. Some of we've already moved you a different supplement or whatever, right? The PDP piece is now what we need to move. If we've already moved the supplement, right? I got to get the PDP moved. AEP is my time. I've got to do it by December 7th. Those LIS only folks, if they're switching PDPs, they do have that drug subsidy after AEP. But it's only for the PDP. I cannot use an LIS election period. So if my member is LIS only, I have to move them by December 7th. If they want to move from one PDP to another, fine, I'll move you month to month. I've got that opportunity. But with all of the plan exits, the service area reductions, that buys a new election period that goes all the way to February 28th. So if we need to buy more road to make more sales, understand that the people or the counties that are being plan exited, if I need to ask them politely to push to the end of the line, they have election periods all the way until February 28th. So if I need to see them on December the 8th, after AEP is over, and use that election period that it's a plan exit, I can do so. So now I've bought myself more selling season. But all of these plan exits and all of these service area reductions also give every one of these people guaranteed issue right for a med sup. If they had a Medicare supplement, got off of it, want to go back to it, and couldn't because of some health condition or whatever, or they were, hey, I want to just change supplement plans or change to a supplement, and now my PDP is exiting, now all of a sudden you have a guaranteed issue right. So understand these election periods and how they work. Now, the big change this year, and the thing that even my agents that have been doing this for years, they're like, I feel like I'm 10 miles behind. I'm underwater. Most of you all feel the same way. Been doing this for 18 years, like I said at the beginning. I feel this same way to a certain extent. Unless I go way in the way back machine. When a private fee for service and a PDP that was matched up with one another was about $37, but the MOOP was $18,000. So I was trying to move people off of med subs and PDPs and exposing them to an $18,000 risk with a $37 premium. Most of that risk was built in the chemotherapy out of hospital charges, and skilled nursing facility charges. So if I go in the way back machine, Paul was selling an MAPD and he was slapping it right next to a hospital indemnity plan. Then Paul got lazy because they kept adding more stuff into Medicare Advantage plans. And then COVID happened. They started just pouring stuff in there. And I could just have all of my agents walk in. They sell one thing. Here's an MAPD. I solved all your problems. I'm paying your bills, buying your groceries, getting you over the counter, getting you your drugs, blah, 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 blah. Boom, 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 boom. Here's $5,000 worth of dental benefits. Those days are over. With the projections of the IRA and the costs of the medical loss ratio continuing, utilization since the pandemic has been way up, and we are an aging population. MAPD will become the dominant aspect of what we will sell in Medicare, but it is not the only thing we need to sell anymore. You have to sell an ancillary product if you want to fully cover a member, especially if you're taking somebody off of a Plan F, because they cannot stand the price of a Plan F any longer. No problem, sir or ma'am. Let me fill in the blank with whatever's available, best MAPD plan available to you. If I can, I'll put in a hospital indemnity, critical illness policy, all of these other things to cover the chemo and the hospital fees and all of those other exposures that are in that MAPD. But if you notice today, right now, I'm wearing a Physicians Mutual hat. I have never ended one of these AEP sales pitches a week or two before AEP talking about something that was not Medicare, either supplement, drug plan, or Advantage in 18 years. For the first time ever, this slide deck has 3 ancillary products on there that are not quote unquote Medicare plans. You have to have these ancillary products ready to sell if you're going to cover your member appropriately this fall. So make sure, even if I'm just leaving them on the plan that I've already sold them, make sure you get the extra plan in there, because AEP is your time for growth. Any questions?
That was absolutely fantastic, Paul. What a wealth of information. So I think for everybody on this call, it would benefit to go back through and just kind of fast forward or rewind to the slide that you need to see, and really try to get this information retained in your minds before AEP. Because that was a lot. That was a lot of information. But
yeah, sorry.
No, that's okay. I mean, we need to have it. And that's what's great about these recordings is you can go back and watch little snippets, recall back in your mind, oh, he said something about, LIS, or he said something about that ANOC form. So this is definitely one that is a rewatch, because all the information you just talked about was spot on and everything that we needed. So, and Annalyn says, thank you so much. We'll definitely watch this video again. So that's perfect. So for you agents out there just getting started in Medicare, you can see that these trainings are pretty phenomenal. It's right where you need to be. If you have any other questions, feel free to reach out to Paul or myself or Eric, and we'll be able to help you to the best of our abilities. And until next time, next Tuesday. One of the things that we actually do want to mention is as we get into AEP, these trainings aren't going to be so pointed. We're going to be on here for maybe about a half hour if you have some direct questions about AEP, but we're not going to be inundating your mind with these trainings while you're trying to be out there selling. We want you to go on AEP. But we will be on this platform every Tuesday, 11 p.m. Eastern, or 11 a.m. I should say. Eastern to answer any questions, and it'll be a question and answer only at that point. So if there's no questions that pop through, guys, have a great rest of your day. Rewatch this if you need to, and we'll talk to you next Tuesday, or Paul will. I will actually be out of the country for 2 weeks. So, but Paul will talk to you next Tuesday. All right, guys, have a great day. Bye now.
Bye.